Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, Faisel and I are talking about doubling down on the triple-double, fresh thoughts on primary care. Let's get started.
Hello, Dr. Dan.
Hey, Faisel. It's good to see you again.
I know. We literally just got back from National Press Club in D.C. yesterday.
That's right, for the kickoff event for the triple-double.
Yeah, I honestly still processing the whole experience.
You know, I've heard people say when you go to a meeting like that, where there's the energy around primary care, you're with your people. And even though we don't work together on a regular basis, it's like going to a family reunion and seeing people that are passionate about the same things that we're passionate about.
Yeah, that's one of the advantages of, I guess, just us being around all this healthcare policy discussions, medical education discussions, whether it was with the AAFP, now Primary Care for America, FMEC, Family Medicine Education Consortium. I mean, these are great conferences, great meetings, but this one definitely felt different. I had to say, it wasn't because of the politics, but it felt like everyone was aligned around something very, very simple. I felt like it wasn't a complicated sell.
Right. And they weren't trying to say there's one way to do primary care. They were saying, however you're doing primary care, whether it's DPC, whether it's one of the full risk models, whether it's private practice, whether it is a integrated health delivery system.
Or community health center.
Community Health Center, yes. NAC is one of the sponsors of this idea. So I think that is just a huge, how can we all work together so we can get more people in the door to help us deliver on this imperative to have more access to primary care.
And in general, the public, we've been for a long time that the country is, yes, we have this massive $5 trillion system, but the country is spending massively underspending and underinvesting in primary care. And so for the public, the way they feel it, though, is with these long wait times where now it has become accepted that, oh, well, it takes months to get in to see the primary care doctor, if you're even seeing a doctor. And when you do have that time, it's a very quick time. And so quick interaction. And so now finally people are starting to, we're seeing people starting to say these things out loud.
Yeah, well, and I think it is. I mean, people are having trouble finding a primary care doctor. I think I told you one of the specialists at UVA. I work in a multi-specialty clinic now, and I got to work one day, and I think I was probably talking to you on the phone driving to work, as I do pretty frequently. And I got there, and I was about 5 minutes late, and I walked in, and they said, "Dr. So-and-so's been here waiting for you." And I'm like, well, boy, I wonder why they were here, and were they something important about a patient or something like that. Anyway, I went and they were seeing a patient, so I left a message and my phone number there, and it came back and found out, well, they were just wanting to know if they could be your patient. They wanted a primary care provider. So, it's hard to do that. I mean, in the past, that would have just been a no-brainer. And I mean, in my mind, it's a no-brainer now because it's an honor that one of the other physicians wants me as their primary care provider. But it is a little bit, we're not used to the specialist waiting for us, right? We're used to waiting on the specialist.
I love the simplicity of the message from yesterday. The triple double,
right?
Basically just doubling primary care investment, doubling access, and doubling the workforce.
Right.
So, but the thing that I want to clarify for people is like the same thing that happened when we were When we first started talking about value-based care publicly, I remember my own family and friends saying, what is this value-based care thing? Is this something to do with Walmart? The value brand at Walmart, that you get. And I said, oh boy, another healthcare slogan, like, but sitting there, this definitely felt much bigger than just some little slogan here.
Right. Well, and I mean, their subtitle from the triple double is the 10-20-40, right? So to go from right now, we only spend 5% of the healthcare dollar in the US on primary care. So to double that to 10%. And right now, only about 10%, which is still a big number, 10% of the US population sees a community health center for their care. But to double that from 10% to 20%, then to increase from 20% to 40% the number of physicians going into primary care, which would get us still below where other countries are. But right now, less than 20% of our physicians are in the primary care workforce. And primary care is the only specialty when you add a primary care doctor to the population that improves outcomes and reduces costs. So that's the imperative of doing it. And we've been talking about that since the 1990s. So again, this is another attempt to actually doing what we know will work.
Yeah, and it was so positive. There was nobody like, oh, it's the insurance companies, it's the hospitals, it's, the doctors are saying the administrator, you know what I mean? Like there wasn't any of that kind of, private practice and academics, like everybody getting angry with CMS. There was nothing like that. It was nothing like that. The outcomes are just so clear. It's like, hey, this current system, the way that it's set up is exhausting literally everybody. The patients, if they have to wait months to get in, they feel abandoned, right? If they're just, patients are tired too of just getting a message in a portal that, hey, your labs are normal. Or if you're lucky, you might get a medical assistant, right? Like doctors are feeling burnt out, nurses are overwhelmed. Since COVID, primary care offices are drowning. And so, there's just too much money being put downstream instead of fixing, what do they say about fixing the front door?
Right. Well, and I was thinking about this. Balint forgot the title of his book, but he had a concept in that about the collusion of autonomy. And of course, he was writing about the program in the United Kingdom, but it pretty much happens everywhere in the training. So we, as primary care providers, we generally have, when you think about the way you go through training, you finish medical school and you become a resident. Well, your first 3 years of the residency, and then the people in internal medicine and pediatrics that are going to specialize stay on a few more years. So if you're an intern, the people who were senior residents when you were an intern, by the time you get to be a senior resident, they're the cardiology fellow, or they're the endocrine fellow, and you're still asking them questions, and now they're the experts. So you get used to being deferential and treating them as the expert. So now when a patient brings you a problem they don't know the answer to, as a primary care provider, and you decide to involve a specialist, you turn it over to the specialist. The specialist feels like, well, they're the expert. They've got to give you an answer, even when they're not sure they have the answer. And if they give you an answer and you don't necessarily trust it, you're reluctant to say anything. So now the patient thinks you're responsible. You think the specialist is responsible. And so there's this sort of collusion of nobody's going to take the autonomy to do that. And I just wonder if that's part of what's happened culturally here, is us as a specialty have been deferential to both the specialist, but also to the administrators, thinking we don't, other people need to manage the business. We don't know how to do that. When in fact, we've got some of the smartest business people I know are the people who've run their own practice for years. I mean, they're pretty sharp at how that happens. And so how do we advocate for the specialty and the importance of the specialty, and do it in a way where we're not colluding into this lack of autonomy to do what we need to do?
Well, I think one thing what you mentioned about just the simplicity of the numbers, right? We talk about this multi-trillion-dollar system, and we're not saying anything dramatic, like, hey, we need a third of this money, or we need 20% of this. Hey, people, we're at 5% right now, and we're talking about going from 5% to 10%. It's so insane because then, like, when you're talking about, what are we doing with prevention? What are we doing with relationships? What are we doing with just, being with the patient throughout the course of their lives? And we're wondering, why all these silly emergency room visits. That was the other thing that came up yesterday. It's like all the silly emergency room visits. Well, with pretty much healthy people. I went to medical school in the Dominican Republic, and I think about the patients who showed up in the emergency rooms over there. I mean, they'd have an arm barely hanging on for dear life. I mean, they were truly medical. And here, because of not having a relationship based system, because it's become so transactional, of course, emergency room visits are through the roof, hospitalizations, chronic disease, because we don't invest. If we're only investing 5% in prevention, of course you're going to see all the stuff that we're seeing. That's what, when you have this hospital run system that is this transactional, and it rewards more of these transactions instead of the relationships, that's the core problem.
And they're working in the business model that they were put into. I mean,
Yeah.
they're smart business people. They've got to every month they've got to make payroll, and they've got to do what they're getting paid to be able to make payroll. And that at some level the system has to change for that to continue to work. Although, I think you're going to see, I've heard you talking about, can we make a better buggy whip? How can we make the system go faster? And I think in the future, I've got a picture of me as an intern with one of my patients. And it's interesting that, so there's this cart sitting beside me in the picture, and it looks like the old stereo system, right? It's got two boxes, it's got wires running everywhere. And those two boxes, one is a 2-lead EKG and one is a pulse ox. And my wristwatch does both of both of those things did. And I mean, it had to have a cart. It was too heavy to pick up and carry it around. So it almost has to be that you're going to start doing more of this as outside the four walls of the big hospitals. People will prefer to have their care at home, and you're going to have potentially AI, either virtual agents or actual robots that will come in and help do that care. And so right sizing the health systems, the people who get it right and figure out how to move it out and turn that into a profitable business are likely going to be more successful than the people who keep trying to create the better buggy whip and figure out how to optimize the number of people in the beds in the hospital.
Yeah, because right now, I was talking with one of my neighbors. He happened to be in DC yesterday. We had an overlap. And I was at a meeting earlier today, and it was funny. It's one of those things, we ended up driving right back in front of each other. And I was talking with him about the meeting yesterday, and he's a technical person. He's got one of these, he's like a computer kind of job person. And even he said, this current system just pays for procedures. The more complicated it is, like if we weren't talking about healthcare and we were talking about, say, a plumbing situation in our homes, and like the more complicated somebody makes it out to be, like, oh, I gotta bring in this person to do this and this person to do that. We had a situation in our home where we had two toilets that were clogged at the same time. And so I don't know anything about plumbing. So I put it into the chat GPT, and the chat GPT came back saying, oh, that's a big problem, because if they're both on the same side of the house, there could be a blockage somewhere down, and you got to get a plumber. The chance that there are two independent situations going on is very low. And so we had the first plumbing company come out. They came and they did the camera, they did the camera and all that. And they came back with an estimate. They said, the house plumbing is 20, 25 years old, and there's a lot of gunk. and they recommended doing a $5,000 flush, for the whole house, plumbing. And I said, okay. I said, okay. I was just so worried about that. I said, yeah, please go ahead and do it. Go ahead and get it done. And then I spoke with one of my friends about it. He said, no, you always got to, you didn't get any other opinions? And I was like, no, I checked it in the AI before, and they pretty much confirmed, what the AI was telling me. And he said, no, 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 we got to get a second opinion. I said, okay, fine. So got a second opinion. And the second plumber came on over, and he did the basic stuff. He came with a plunger, and he said, problem solved. And I said, what? He said, problem solved. And he said, I feel embarrassed to charge you the $75 to come out over here. He said it was just happened to be two clogged toilets on the same side of the house. And I thought to myself, I said, boy, here's somebody like him who felt bad charging me $75. And I ended up wanting to do something for him. And I ended up paying him much more than that just to have a nice dinner with his family, to do something. I was just so appreciative. But we don't do that in healthcare.
Well, I mean, some models do. I mean, you're talking about somebody taking risk. I mean, if you were having to pay him instead of $75 one time, but you and all your neighbors were each paying him $75 a month to keep your plumbing working. I mean, and he coming and using a plunger kept you from calling the guy to do the $5,000. He just made $4,025, right?
Yeah,
Or
sure.
49 $4,925.
That's right.
And so, yeah, I mean, it's different. I was listening to a podcast coming home, and it was a financial advice podcast, but the author was talking about, he had an old car that the tailgate wouldn't work, one of the big Toyotas, and he took it to the dealership. He said, because he had a similar thing a couple of years ago, and he found out that it was a little plastic thing you needed to fix, but he was in a hurry and didn't have time to do it. And he was getting the dealership to look at something else. And so he had them look at it, and they said, oops, your tailgate assembly's shot. We got to put a whole new tailgate in it. And it was like you were saying, it was like $5,000. And he's like, well, this doesn't sound right. And anyway, he got to looking on AI and realized it was this one piece of plastic that he needed, and it even gave him the part number. And he walked over to the parts department, and they said, do you have this? They said, yeah, it's like $20. And he said, yeah. He said, I bought that. He said, when I got home, it took me about a half an hour for AI walking me through it, but the tailgate was fixed. But I mean, they were just wanting to replace the whole thing. And that's sort of when you start thinking about, if you're an orthopedic surgeon, you do joint replacements, right? Are you thinking about what's the patient, what's important to them? What do they want to be able to do? And do we really need to replace the whole hip assembly, or is there something else that will allow them to maintain the function that they need? Now, you don't get paid as much by doing that, but it could be. It is an interesting world we're living in, because right now the people who do, like the plumbers, the surgeon was going to get paid $5,000. The guy who was thinking only got $75, although you gave his family a nice dinner, and he didn't have to tie up a bunch of money in cameras either. But it is interesting to see how it works, and how do we add the value about primary care. I was looking at an article, a lot of times when you read the articles in the newspaper about some healthcare or something, it's somebody that had a catastrophic illness, or it was a big save, right? Yeah. They got their cancer treated. They got their bypass surgery. They got their transplant. They got their drug to treat pancreatic cancer, which all these are devastating problems, and it's great. But what we don't hear is the family doctor who got them to start taking their statin drug, 20 years ago. So now they haven't had a heart attack, right? And they're 80 years old. They've lived until they're 80, and they really haven't had any they haven't had any clogged toilets. They haven't had to call anybody, and we don't have that. We don't have a way to appreciate that or highlight that.
No, no, and like I think about Dr. Vigrass, Howard Vigrass from Columbus, Georgia. Sadly, he passed away earlier this year, but just one of those traditional family doctors. And I can never forget the way that he was such an active listener. You know, the way that he would reassure someone. He loved rheumatism. He loved all the rheumatologic, and the way that he would put his hands on a patient's hands and their fingers in such a reassuring way. And in the beginning, when we didn't know what he was doing, you know, we were wondering, boy, he was awfully intimate with this patient, and for minutes. I'm not talking. He didn't have time. You know, he was a busy doc. He didn't even at that stage of his career. He was very busy, but in those intense minutes, intense moments, the trust that he had and the trust the patients had with him through time because it was a longitudinal thing, that's no longer rewarded. You know, his patients would not go to the emergency room. I mean, it would almost be an offense to him. You know, remember in residency before even doing a single referral, especially in family medicine with the older attendings, it was really, I mean, you had to exhaust. It was a pretty big deal to refer out. I don't even remember doing it, you know, really, I mean, unless they needed an intervention done, you know, and if it was that serious, we just admit them to the hospital.
Yeah, no, I mean, I remember, but we had to have the permission. But now it's gotten so busy. I remember it's probably been 5 or 6 years ago. Somebody shared there's a national survey of residents that have been out for a certain period of time, and something like 70% said they had never gotten any education or feedback when they were making referrals about what a good referral was or how to do it.
Yeah, yeah, yeah.
And it's really important to know what question you're asking. What, you know, what do you, what, what do you expect to get out of this? And it's not, oh, here's the potato. It's yours now. Right.
Because that's what happens. This, what were you calling it? The collusion of anonymity.
Yeah, right. And so, yeah, so you just ask them to, and you don't ask the right question, and then you're frustrated that you didn't get the question answered that you had, and the patient's upset because nobody listened to them about what they wanted done. And it just, I think it's really important to know, you know, to be clear about what you're delegating to somebody else and what you want to keep for yourself. I mean, we have the opportunity here to, there's always a little box when we do a referral to check. Do you want them to take over management of the problem? Do you want them to do a procedure or send the patient back? Or do you want them to follow with you? And for the complicated chronic illnesses, that's usually the one I'm checking, is I want them to follow with me. I don't want them to take over management of the problem. I want them to give me advice and then figure out how often they actually need to see them back, and let me do the month to month stuff. If they can check in once a year and I can do everything in between, that's going to be better for the patient and it's going to be better for the practice. Now, I don't know about financially. It is, because they tend to order more diagnostic studies than I do.
You know, where we're talking about what you could refer, what you couldn't refer, asking the right question, even being particularly, you know, intentional about the referral, we're not seeing that, you know, because the medicine that's being practiced today, because of the high volumes and the burnout and all of that stuff, doctors don't hate medicine. They just don't recognize this new world that we're in right now, right? That's very different. It's one thing to hate medicine, to get into it, and then you hate. I don't think that's the case. They just don't recognize it. Yesterday, they split us up into groups when we had the workshop breakout session. That was the first time that I felt comfortable talking about like the big ugly secret that drives a lot of the waste in healthcare delivery today. The amount of unnecessary emergency room visits that's driven by fear. Like people going to the hospital just because they're scared, or the clinic, nobody answers the phone, or it's some automated thing when they are answering the phone, or they're speaking to a triage person who doesn't fully understand what's going on, right? Like they don't trust the system, right? We're living in a political time right now where a lot of the general public has lost faith in the institution. So we got to do a lot of that rebuilding. Or they're just lonely. You come in a Friday evening and you say the right things, there's a good chance that you will be admitted to the hospital and that you'll be there till Monday. And yesterday was the first time that I felt comfortable talking about that. If we reduce fear early, you reduce all these downstream catastrophes.
Right. Well, and the thing, and it's not, I mean, it's not as easy as just saying, well, this is an unnecessary admission. We're just going to send them out. That stress impacts their other conditions. I mean, I shared a graph with you of a patient who had 11 hospital admissions in 2023 and only one in 2024 and none since then because the medical home team and the primary care. So, but what's happened, he's gone from not being in the hospital and no admissions to where he's doubled his cardiology visits. He's more than doubled his primary care visits. And he's got the medical home nurses doing home visits, at the rate of about one a month. So you could argue, well, his utilization's actually increased, and on a piece rate it has. If you're looking at a dollar utilization, it's markedly decreased, right? You and I both know that we could pay for a year of that other care for what one ICU stay would cost,
Sure,
right?
sure.
So, I mean, it makes a huge difference, and they're staying healthy and out of the hospital. So, well, Faisel, we could talk all day about this, and I know we've sort of gone around, but I mean, needless to say, there is a big shortage of being able to provide those relationships, and we need anybody who's listening to this to get interested in the triple double and look at helping to increase the resources going into primary care and the people going into primary care and the access that people are going to have.
What are your thoughts on doubling down on the triple double? Fresh thoughts on primary care. You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.